What is up, Z-Pack? It's your boy, Z-Dog MD. Today I have a special guest, Dr. Dylan Carney, emergency physician, brother from another mother. And we're going to talk about something that's crazy important, which is medication-assisted therapy for opioid dependency. We don't like to say addiction anymore, do we, Dylan?
Yeah, that's fallen out of favor.
Why? Why is that?
Ooh, that's a great question. I think it just carries a little bit of stigma with it. So we use dependency or opioid use disorder nowadays.
Yeah. We got so Dr. Brown's in the back. By the way, there she is. What up? What up? You guys remember Denise Brown? So Denise Brown did a show with me. She's from Vituity, and so is Dylan. Vituity is the company that's sponsoring this show. They're just giving us backing to talk about things that really matter, that they're actually involved in, but it's not even a commercial for Vituity. It's us being able to actually talk about stuff meaningfully. Yeah. And medication-assisted therapy is crucial because when people show up to the ER with opioid dependency issues, whatever you want to call it, whatever the PC term is right now, it's causing lots of suffering. And it's causing suffering for our frontline staff because we have no tools. We just say, well, okay, go into a rehab program that I know you're not going to do or you're not going to be able to afford, or I have no tools to treat you aside from giving you Dilaudid and telling you to go, or throwing my hands up and then wondering why we're seeing more violence in the emergency department. And so how did this sort of shape your path? Because you're like a Stanford trained dude, UCSF, all this other hotshot stuff, but you're struggling with the same issues that anyone on the front lines is struggling with. How did that then lead you to medication-assisted therapy? We'll just call it MAT from now.
Yeah, absolutely. Well, thanks for having me here on the podcast.
Oh, my pleasure.
I think this topic kind of creeped up on me and was something I didn't anticipate finding myself in. But training over the last 10 years and starting my practice, of course, the opioid crisis has been increasing, and I'm seeing it more and more in the emergency department, and everyone is, no matter where you are. So over 2016 to 2017, we saw about a 30% increase in ED visits for opioid overdoses and opioid-related problems.
Where are you mainly practicing now?
I practice right now at Marin Health.
Marin, okay, gotcha. California. Yeah, we were up there recently, yeah. Yeah, okay.
So when I finished my residency, I did a fellowship in administration and management with Vituity. And during that process, we picked kind of like a thesis project to work on.
Wait, so you were training to be an evil administrator? Is that what I'm understanding?
Yeah, exactly. Yep.
I'm sorry, this interview is officially over. No, keep going.
Yeah. And at that point, there was a lot more evidence that we should be doing buprenorphine or medication-assisted treatment out of the emergency department. And actually, it was something that had just started during my chief year in residency at San Francisco General. And so even just with that 1 year of kind of experience using buprenorphine in my own practice, I became kind of a sort of relative expert, and I just kind of ran with it, and I continued kind of learning more about it. And for my project, decided to work with all of our other emergency departments throughout Vituity to train their docs on how to use buprenorphine to treat opioid use disorder.
So buprenorphine is Suboxone, correct?
More or less, yes.
More or less.
Yes.
So you're talking about really, truly doing medication-assisted therapy, which you're going to see in comments. So people get very triggered by this idea of giving a drug to treat dependency on a drug.
Exactly.
How do you think about that in a sense, in terms of this sort of trade-off between, are you then making them dependent on another drug, and as an emergency physician, how does that work?
Yeah, that's the number one question I get is, aren't you just replacing one drug with another or one addiction with another? But Suboxone or buprenorphine is not really not a frequently abused medication. It's not euphoric. What it does is it helps treat people's cravings and stay off of use. Everyone in this area will cite a big study from 2015 out of Yale, where they did a randomized control trial, and they looked at patients who presented to the emergency department with opioid withdrawal, something we see very frequently. And they randomized them to one of three arms. In the first arm, patients got a referral to treatment, which is kind of, I'd say, the standard of care. You know, a lot of places when patients come in with opioid use disorders, you have kind of a list, a piece of paper of referral treatment centers, and you say, good luck, go follow up with this program.
Yeah, I've been there. Yeah. Not as a patient, or I'd be violating my own HIPAA, but as a clinician.
Well, fair enough. I mean, the opioid crisis affects everyone in their own families as well. So I can't name one person who doesn't have someone in their family or friend group who hasn't been touched by it.
Yeah. By the way, weigh in the comments if you have a family or a friend who's been touched by this, because I tell you, it's overwhelming, actually. Yeah.
So arm one was you get a referral to treatment. Arm two is you get a brief counseling intervention referral to treatment. And then arm number three was you actually start buprenorphine buprenorphine in the emergency department in a referral to treatment. And they found that the people who actually got their first dose of buprenorphine in the emergency department were nearly twice as likely to be retained in treatment 30 days later.
Wow. So just the act of getting that first dose there was more likely to lead to 30-day, what we'll call
retention.
Success, right?
Yeah,
Retention.
exactly.
Whereas, so the other options were just like you're referred, and then the other one is you're counseled and referred.
Yep.
And how big was the trial again?
Ooh, I don't know how many patients.
Right.
Yeah,
but it was big enough to show a
No.
statistical
Yeah.
significantly difference there in outcome. So why do you think that is? What's going on?
Well, the other awesome benefit about buprenorphine is it's the best medication we have to treat withdrawal. So withdrawal is a really challenging thing to treat without using an opioid, right? So you get someone who's nauseous, they're vomiting, they feel awful, they have abdominal pain, they're shaking in real florid withdrawal because they tried to quit maybe 1 or 2 days ago. And they come in for help and you give them some Zofran, maybe you max out your Zofran, you give them Tylenol, ibuprofen, IV fluids. They're still barfing and you're not getting anywhere.
Yeah.
They're in your department for hours and hours, and then maybe sometimes you even admit them because you can't get them comfortable.
I've had that call.
Yeah. And then sometimes you give up and you're like, okay, how about I'll just give you a small dose of an opioid, or maybe I'll give you 1 dose of methadone.
Yeah, methadone, right. Mm-hmm.
Or tell them to why don't you go home and try to taper it yourself instead of quit cold turkey? Or what you do is you skip the middleman, you just start them on buprenorphine. And within 1 hour, they can be symptom-free and feel great. And it's when they leave the department feeling fantastic, and when their symptoms are gone, then they're like, wow, this is a great medication. And that's their destination treatment. So that's what they're going to be on. That's what their provider is going to start them on as an outpatient.
Why is buprenorphine physiologically affecting them this way? In other words, does it also have an antagonistic function to opioid receptors? What's going on?
Yeah, it's like you're a plant.
And the truth is, listen, all joking aside, we've met 5 minutes before we did this, but I just heard what his topic was, and I'm like, we need to talk about this. So he's teaching me, and honestly, I'm not an expert in this, so I'm learning along with you guys.
Yeah.
So
Yeah, so when I first learned, it seems very complicated, but actually, buprenorphine is an opioid agonist and an antagonist in one. So what that means is you can give it in lower doses, it acts like an opioid. You can actually treat pain with buprenorphine. There are people who are on buprenorphine for pain. But in higher doses, there's a ceiling effect. So unlike morphine, where you give more and more and more, and you get more respiratory suppression and sedation,
right,
you have this ceiling effect with buprenorphine so that you do not get respiratory suppression and sedation.
So can you overdose then at all on buprenorphine?
I'm not going to say that you absolutely cannot.
Right.
There are cases of reported overdoses, but they're usually polysubstance overdoses. So it's mixing with Xanax and alcohol and all this other stuff.
Which, by the way, we'd be remiss if we didn't say the co-administration of benzodiazepines, suppressants, and opioids or other drugs is a toxic stew of disaster. So don't do it. The one advice, so I was dating this girl in high school, and her dad was the teacher in the band at our high school. And I was like a band geek when I was younger. And so he was like a father, he would be the surrogate father figure because my dad was Indian and didn't understand the American system at all. And he said, you're going to Berkeley as an undergrad. The one piece of advice I'd give you is don't mix drugs. He didn't say don't do drugs. He's like, don't mix drugs, which I think is very good advice. So
fair enough.
Back to buprenorphine. So there's a ceiling, assuming you're not polysubstance. That's the advantage. So it can treat withdrawal and it can treat dependency. And what's the theory on dependency? What's the idea there? How is it helping with that? How are you not just substituting like methadone for morphine, another narcotic for another narcotic?
Yeah. Well, even when for the dependency, it really prevents these cravings. And these cravings persist for a long time. People who are who have abstained for years still end up with cravings. And people who are on buprenorphine or Suboxone for years, when they wean themselves off, they oftentimes find these cravings coming back. And then the partial agonist antagonist has another interesting effect, which means that if you're not in withdrawal to begin with, say you use IV heroin and you just shot up, and then you go take a bunch of buprenorphine, it has such a high receptor affinity that it's going to kick off all of that heroin and put you into withdrawal.
Oh, so let me ask a question then relating to that. Someone comes in, EMS, they're all out of Narcan. Could you give, and their respiratory sedation, they're unconscious, you would normally give Narcan. Let's say it's all gone, you're on a desert island. Could you give buprenorphine?
So
Or would it make it worse?
That's an awesome question. I think we'll start to see some research on that. It's something that we've heard people do in the field, and that if your friend just overdosed and you guys don't have Narcan, but I'm on buprenorphine, you can maybe put the sublingual strip in that person's mouth, and there are reported cases of people being reversed.
So then you could change the name for that application and get a new patent and call it Buprenorphine. Like, bro. I got you. Okay, that's really dumb and also inappropriate. So that being said, okay.
And then there's a thought that like if we use this to reverse someone, it's a more gentle reversal than Narcan.
Yeah, because they're not going and shouting curse words and hurling feces. Right.
Although if they are doing that, you can give them buprenorphine.
That makes sense. So you've hit them with Narcan. They're jumping out of their skin, screaming bloody murder. At that point, you can give them a little buprenorphine.
Yeah.
Dude, that's awesome. So I'm learning a lot here. So let me understand this now. How do you initiate therapy in the emergency department? Do you have to have counseling? Do you have to have a plan for discharge, or can you just give them buprenorphine? Do you give them a prescription? How do you go about that?
All great questions. I mean, ideally, you do have counseling and all of the other support services. Adequate treatment of opioid use disorder is not just a single medication. It's all of the treatment and counseling and case management that comes with it. Unfortunately, buprenorphine has some special licensing requirements that make it really hard for providers to just prescribe it. So you may have heard about the DEA X waiver or the Data 2000 waiver.
Explain it to us.
Yeah. So if you have a DEA license, you have a license to prescribe narcotics.
Yeah, baby.
There you go.
I'm the candy man.
But unfortunately, you can't prescribe buprenorphine. Because
that is dumb.
Yeah.
Yeah. Continue.
So in order to prescribe buprenorphine, you need this thing called the DEA X waiver. And it's an 8-hour course for docs to take. You can take it entirely online and for free.
8 hours, though.
8 hours, yeah. I've heard you can click through it a little bit faster than 8 hours. I didn't say that, though.
Yeah, that was not said.
And NPs and PAs can do it as well. For them, it's 24 hours. Again, onerous. But, I mean, I can teach you doc to doc or doc to NP or PA within 15 minutes. All you need to know to feel comfortable giving this. And interestingly and importantly, in a hospital setting or emergency department setting, as a hospitalist or emergency medicine provider, you can administer it without the waiver because you're operating under the license of the hospital.
Ah, that's important to know.
Yeah. So just like residents when they start out can prescribe at a hospital.
Right.
Any ED provider can start this without getting a waiver.
But can you send them with a prescription, or you can start it with a prescription still, or no?
So you can do either. So if you have the waiver, then you can send them with their prescription.
Right.
If you don't have the waiver, fortunately, the half-life is like 23 hours. And so you can load them with enough buprenorphine that their symptoms are going to be managed until they follow up. And that's where you really need good linkage with an outpatient treatment program. Now you're not just giving them a piece of paper and saying, good luck. You are giving them, hopefully, an appointment tomorrow.
Dumb, crazy, stupid question from a hospitalist that doesn't know this stuff. Is it PO only, or is it IV?
It is everything.
Everything.
Yeah, sublingual usually.
Per rectum? Because that's how I like my meds. I'm just saying. No judgment.
Probably.
Yes. And then the other question is someone here, Thong Trin, is saying, Suboxone crazy price, $3,000 for per 300 month cost. I think he means per month, maybe. Is it how expensive?
So that may be their formulation because it's generic, and you can get a sublingual film that's generic and cheap.
Oh, got it.
And it's covered by almost every payer.
Sublocade.
Yeah.
Got it. Yeah. And there's, okay, right. And what about people?
So Sublocade, that comment, that actually refers to another concept, which is that if a person's opioid receptors are blocked by buprenorphine, then it's protective. So I give a patient a ton of buprenorphine and send them on their way. Say they say, screw this appointment, I'm not going to go into treatment right now, I'm going to go shoot up. You've kind of blocked their receptors for the next 24 hours.
You're like their wingman that's actually trying to get the girl.
Exactly.
And totally blocking. So okay, let me rewind for a second. So it seems to me like this drug, apart from the obvious harm reduction, can be used in a variety of circumstances in the emergency department to prevent death and suffering. Why isn't it used more? What are the blockades against this, apart from cost and the things we talked about? And the fact that because you don't need to have all that training if you're an emergency department provider.
Yeah.
So
and I would say not just ED, but inpatient too. I mean, this
Right.
affects our inpatient colleagues just as much. You admit someone for cellulitis, they then tell you that they're on opioids, they then go into withdrawal. These patients AMA at a 30% rate. So 30% of these patients who start withdrawing end up AMAing from your
Dude, by the way,
service.
I got to say that's great dispo for me. 30% discharge rate. That's barely any paperwork.
Yep. Fair enough. Or you
Yeah.
start them on their treatment and then they don't bounce back. So you save
That's
yourself
good
that
too.
readmission.
That's good too. So again, preventing bounce backs, hospitalists, other docs in the hospital can do it. Emergency department providers can do it. And again, you learned about all this through your fellowship at Vituity, this administrative fellowship? Is how you got
in
pointed
a
down this?
combination from the administrative fellowship and then getting to work with a lot of people in the community. I mean, Yale and Highland have been doing a lot of the research and kind of pioneering this.
Highland in Oakland?
Yeah.
Great place. My buddy did his training there as well. Well, so, and again, guys, this is not to pitch the sponsor of the show, but I'm going to pitch the sponsor of the show. This is why we work with companies like this. I promised you guys I was never going to work with shitty, stupid companies again. And again, I'm not even supposed to curse on sponsored shows, but I'm just being real here. These guys are awesome. Their leadership is awesome. Their doctors are awesome. I run into them on the street and they're like, oh, we saw your show with Denise. We love working with these guys. They're doing the right thing. And these are the kind of organizations and bright spots we should promote. If you're saving lives, if you're teaching people about buprenorphine. So what else around that topic before we take some comments would you want to make sure we knew that I'm not asking?
I mean, it really is a lot easier than you think. You asked why we're not doing it more often, why not everyone's doing it. 2 years ago when I started working on this project with all of our sites, we surveyed everyone, and there are about 9 sites doing this in our group of emergency departments. And then we asked them again a year later, are you guys doing buprenorphine? Are you starting a program? And that quadrupled in 1 year.
Oh, wow.
And so there's more and more interest in doing this. A big component is education. And then I think the other big component is kind of there was this big study a while back that showed it takes 17 years for evidence to become standard of care.
Sounds right.
Yeah.
That's actually conservative.
Yeah.
Mm-hmm.
And so it's the translation of that evidence that really excites me. How do we get like a bunch of docs who maybe trained 1 year ago or 25 years ago? How do we teach them something new? How do we show them all this evidence, and how do we translate that into practice?
I'm gonna give you a hug because that's the whole point of what we try to do here on the show. So in this episode, we might reach more people in a single episode than 10 years of conferences. So, and exactly. You can impart now. See, now they're going to want to go out and they're going to learn how to do this. And whether you're teaching them or someone else is teaching them, it will transform care in a catalyzed amount of time.
Yeah.
That's right. So I'm a big believer in this platform for that purpose. So thank you for bringing that wisdom to us.
Absolutely.
And one thing I wanted to ask you about too was, how does this relate? Because we were talking in our 5-minute pre-show, we were talking about caregiver wellness. Mm-hmm. So the nurse practitioners, the PAs, the doctors, the rad techs, everybody else who's touching patients on the front lines. How does this affect them when we're, quote unquote, burning out? Like, okay, 1 second. Yeah. I talk about moral injury a lot, right? Mm-hmm. Like this idea that we are forced to do things that are morally repugnant. It's morally repugnant to me that we would put a patient out on the street with no capacity to help themselves when we know they have a fatal illness, which is opioid dependency, and we do nothing. We're hamstrung, we're powerless, and we're afraid. And to some extent, we created this epidemic, co-created it by handing this stuff out because, pharma told us this was the thing to do to treat pain, and we're worried we're going to get sued. And think of the conflict, right? So how does this affect that sort of wellness component of what we're trying to do?
Absolutely. We talk a lot in wellness. There was, I think, the Stanford model that has 3 arms, and one of them, I think, is efficiency of practice. And I think of that as like, I went into emergency medicine because I like to be able to treat everything. I think of myself as like having this quiver of solutions for everything. But up until this, I didn't really have a great solution for opioid use disorder and opioid dependency.
Yeah.
So these patients come in, and like I mentioned earlier, they're vomiting. They feel awful. I'm trying my best with all my non-opioid medications to get them comfortable, and I'm just not succeeding. And now suddenly, we have this medication that we can use that not only makes them feel better immediately, but it actually improves mortality, it improves retention and treatment, it reduces healthcare costs because these patients stop bouncing back as much. So when I go to work and I have solutions for all my patients, that's a shift that I feel like I want at. Whereas if I go to work and I just don't have solutions and I can't fix anyone's problems, that's where I feel burnt out.
God, I love this man so much. That's the heart of it. Finding solutions. I'm tired of complaining. I'm tired of feeling hurt. I'm tired of feeling burned out. I'm tired of feeling powerless. Learned helplessness is so terrible. And here you are, young kid, fresh-faced, goes out and says, oh, I have a solution. Let's start pushing it. It's there in front of us. Why should we wait the 17 years for it to become practice, right? All right, at this point, I'm going to say bye to people who want to check out. And if we end up sharing this clip as a smaller clip, we might cut it right here. So thank you. Hit share on this one. Spread the word about medication-assisted therapy for opioid use disorder. Now we're going to take questions. So, Dr. Brown, was there anything that popped out at you, or should I start peeking them? Yell at me. Holler at a boy.
So how long can you take this? What's the kind of duration? Would it be safe to take it for 5 years? Would it be safe to take it for 10 years?
Yeah. So what's the duration of safety for using this?
Yeah.
Do you have to use it for life?
You can. So it's safe to take for life. And, this is where we hand off to the addiction specialist, because I think that is a patient-specific answer. There are some people who are really motivated to taper off of it. There are some people who use it for a year. I had a patient the other day who developed dependence within 30 days after her knee replacement and came in because she tried to quit her meds cold turkey. And that might have been a patient who really only wants to be on it for a little bit of time because her dependence was new, just developed in the last 30 days. Although I've also seen people who have been on buprenorphine for a year or two, they tapered themselves off and then relapsed and came back into the emergency department to restart.
Okay, I'm going to read this comment because it's provocative in this sense, all right? So Richard Wan says, if Suboxone strips work, why doesn't Alcoholics Anonymous adopt a shot of whiskey a day to prevent alcohol abuse? This is about money. Money for the docs that are specializing in it, except you don't get paid, and money for the manufacturers who make this stuff. I've never seen any definitive proof that opioid maintenance works long term. Okay, I'm going to answer one part of this, and then you can take the second. Okay. The reason that AA doesn't give a shot of alcohol for alcohol dependency is twofold. Number one, alcohol is actually a direct liver toxin and will kill you over time, whereas this is actually reasonably safe, all right, except for constipation and those sort of things that you get with opioids. The second thing is that alcoholics cannot drink a shot of whiskey without going down the rabbit hole of drinking a whole bottle of whiskey. Buprenorphine has that ceiling, so you're not going to go down this rabbit hole and end up, in trouble with that. It just is not physiologically likely or possible. Now, your thoughts on this?
Yeah. So, in terms of the financial aspect, it's a generic medication and I don't bill any different. There's no billing difference. It's just an ED visit. So it doesn't matter whether or not I treat it with buprenorphine or I treat it with something else. What was the second component of the question?
The second component was, I've never seen evidence that it works long term.
The evidence. Yeah. Well, there's a big meta-analysis that looked at every trial of medication-assisted treatment. So every randomized control trial. And there were at least 20. And all of them showed a reduction in mortality when you compare patients who are on MAT to patients who are not. And I'll qualify that and say 15 of those studies at least were methadone. And so there have been a lot of questions about methadone here because the concept of MAT is giving a medication to treat symptoms of withdrawal and cravings. And so there are 3 medications we use for MAT. There is methadone, there's buprenorphine, and then there's naltrexone. Naltrexone is a long-acting kind of Narcan opioid blocker. And so I know that methadone conjures up a lot of kind of fear in some people's minds. I mean, we
going
see a
to
lot
the
of
methadone clinic, overdose, long-acting. Yeah.
And that has a different set of kind of regulations federally. And for a lot of reasons, we can't necessarily start someone on methadone. But the honest truth is that the outcomes are great on methadone as well. Mortality improves on methadone.
Well, real quick, Robbie Westerman said, I never got high on my Suboxone. It gave me a life. Robbie, weigh in. Are you still on maintenance, or were you able to get off? Because I think one of the questions that I think I have always is, what's the root cause of opioid dependency? Is it some deep, unconscious, need, emptiness, void that's psychological that can be dealt with over years with therapy? Is it a physical receptor, genetic tendency, or is it a mix of those things?
Yeah.
What's your instinct on this?
I mean, I think it's a mix of everything: your biology, your genetics, your environment,
right?
Kind of like everything else.
This
kind
hungry
of
ghost
biology.
theory. Some people have put out that there's this part of the. So when you take that again, you take one piece off, you go, okay, let's satisfy the receptor piece. Now let's dig into the therapy. So Oh, yeah, go ahead.
I was going to say some people start because they had a knee replacement and that was their first use of an opioid. Other people start because they were having a really hard time in their life and they turn to using. And then some of these people have an easier time stopping and other people have a harder time stopping. So I think it's a case-by-case scenario.
Tanya, thank you for the stars. Dr. Brown, you had a comment.
Well, I think Vanessa Medina has talked a couple of times about something that's recurring here on some of the comments, and that is, how do we address the stigma? So we're trying to address a medical issue, a crisis of epic proportions, but then there's still somehow this stigma attached to Suboxone or to buprenorphine. What should we be doing about that?
This is a great question because I can tell you in the comments I see the stigma.
Yeah.
So how do you think about that?
It's constant. It's not going to change overnight. I think this is just where we have to keep leading, keep being the positive change agents, keep talking to everyone about this, talk openly about it. When you approach a patient without judgment and just ask them openly, they answer openly, and you learn a whole lot more. And we should talk to our colleagues this way. And I think also, I try to connect with my colleagues when I do sense a little bit of stigma, whether that be another provider or a nurse. Like we said earlier, it's touched everyone's family or their friends somehow. So it's something we can all relate to.
I think personally, and this is my own philosophy, I think moralizing about this stuff is not productive. And I think, again, holding accountability is important, but I think moralizing about it doesn't help because we are largely driven by these unconscious things that happen. And so anything that we can do from a system standpoint to nudge individuals in the right direction, in a harm reduction direction, in a direction that is better for their family. Forget about them. Let's say you think they're a piece of crap for being a weak person who's addicted. And there are people who think this. I disagree with them strongly, but think about their families. If there's a way you can protect their families from the addiction, the sequelae of that addiction, then wouldn't you want to do it? And if it's a chronic disease, we have diabetics on metformin for life. We have diabetics on insulin for life. Why can't we have somebody who suffers with this disease on it for life if they're productive members of society, they're doing okay, it doesn't have a lot of downside except for cost, and I bet the cost will come down the more you destigmatize it. And use it. Yeah.
And even if you can't put your stigma away, there is so much evidence, you can't ignore the evidence that it improves outcomes, it improves mortality, it really achieves that IHA, triple aim, quadruple aim, reducing costs, helps me in my efficiency of practice.
Go ahead.
So I got another one from Matt Slossman. What's the potential pre-hospital application? All the paramedics are getting fried by repeat overdose patients. We're slinging Narcan like crazy. Is this something we could look at seeing in the field in the future? And I think, when we talk about burnout, we talk about moral injury, we've got to include all those first responder paramedic guys who are really seeing this up close and very personally sometimes.
I got to talk to you guys direct for a second. The pre-hospital people send me the most impassioned messages of anybody. They are suffering, you guys. And remember, these are guys that get paid a lot of times minimum wage to do the kind of work that would give a tough, burly dude, stereotypical masculine person PTSD for the rest of their life. And so this question is very valid. Can we improve the conditions and perceived power and efficacy of our frontline pre-hospital staff with this solution?
I mean, they have been the most eager colleagues I've seen. For every case that I see, they see many more because they're seeing patients that decline transport. They're seeing cases that expire in the field and don't come in. They see a lot more than we do, and they have been leading the way, whether that is distributing Narcan. And I believe, don't quote me on this, but I believe that there are some EMS systems that are trialing initiation of buprenorphine Suboxone in the field.
Oh, wow. Yeah. So good. So we're starting to look at it. We're starting to study it. Okay.
Absolutely.
Other thoughts or questions? This has been an insanely helpful discussion for me because I get asked these questions a lot and I keep telling people, look, I understand the vagaries of it, but I need to talk to an expert, and now we have an expert, and I really want to thank you, Dylan. This was super helpful. I think if it influences 5 people in this audience, and there have been like 500 people watching, live, 5 people in this audience to go out, learn more about it, implemented in their own emergency department, hospital, whatever, pre-hospital paramedic on their rig, and it's part, or it starts a new trial, we've done good, I think, because I'm actually a believer in this approach. And until we figure out the root cause of addiction and figure out how to target that, we have to treat we treat it the way we do, which is like this, with medication-assisted therapy.
Absolutely. And the field has developed some awesome toolkits and protocols. 2 years ago was an entirely different scene. Developing the protocols was a little bit more challenging. Now we have them. If anybody wants to learn more, feel free to email me. I'll give this guy my email address so you can put him in the show notes, and I'll be able to share information. We also published a white paper with Vituity on how to start MAT out of the ED. So we can get that to you guys if you're interested in that.
Ping us. So we'll make sure to have contact information available in the show notes, potentially in the description and in the stuff when we repost it here on YouTube, on the podcast if you're listening, and elsewhere. Denise, you had a follow-up from...
I just wanted to give a special shout out to Robbie Westerman. I think your comments have been incredibly insightful. It's kind of like a hair club for men thing. This is a guy.
I'm also the president.
Yeah, no doubt. Who has basically gone from a user of this medication and a homeless guy to now almost finishing his nursing practitioner degree.
Oh, wow.
And I just think that is pretty flippin' spectacular. So I just wanted to say congratulations, and we're all very proud of you.
That's great.
I have goosebumps, dude, and that's unusual for me because I've had my goosebumpectomy. I had a total parasympathetic, so this is like a violation of the laws of nature. Yeah. Robbie, congratulations. Thank you for weighing in. Thank you for being so honest and vulnerable too in your own experience, because there's so much stigma. And the truth is now you're going to go on to this amazing life, and you go from homeless to having a life. And I think that's the most powerful sort of statement that can be made. We can't make statements like that because we're third parties to this. Yeah. So thank you again, Dylan. What an honor, man.
Thanks a lot. Thank
you, brother. Will you come back on the show in the future?
Absolutely.
And I want to shout out Denise Brown and Vituity for making this possible. This is the kind of partnership we want to keep having, you guys. And I want to thank my supporters who support us with $5 a month doing this thing. They make all this stuff possible. I have all this cool gear because of them. And also the sweater. I use their money to buy a sweater. Nice. Because I need one. I'm cold, people. All right, guys. I love you. Stay safe out there. Share this video. And we out. Peace.